Good afternoon, everybody. My name is Lewis Myers. I'm the Senior Director of Sales at SomnoMed, and I want to welcome you all to our Sleep Partners series of webinars. I want to welcome Dr. David Schwartz, Dr. Andrew Mouton to the webinar today. But first, this being our first of 6 webinars, I wanted to kind of explain how this came to be, where the idea came from. In these times of webinar overload, it occurred to me that we hadn't really seen much about the MD-DDS relationship and what it takes to really make one outstanding. Where bidirectional referrals are going back and forth, patients are receiving the very best care, and both the physician and the dentist are greatly benefiting. So the purpose of today's webinar is to dive into that relationship with Dr. Schwartz and Dr. Mouton. And in forthcoming webinars, we'll have Drs. John Viviano and Ken Mogel on, along with their top referring sleep docs. But our conversations soon turned to more than just the physician-dentist relationship. We started discussing other partnerships that drive success in the dental practice. And several practices out there employ a full-time sales and marketing pro, for example. And perhaps you've thought about doing the same. We hear from our dentist customers all the time when we're talking about meeting with sleep docs and doing lunch and learns. I'm no sales guy, or I don't have the time to do that. So Drs. Kent Smith and Brandon Hedgecock will be featured in separate webinars along with members of their sales team to share with us what they do and the success that they've had in driving MD referrals to Sleep Dallas and to Sleep Better Austin. And lastly, Dr. Stacy Lehman has a very unique relationship with the founder and president of one of the largest independent sleep diagnostic centers in Arizona. And they've been referring back and forth for years. We're excited to have Dr. Lehman and Lori Headley on as well. So let's get started. Dr. David Schwartz, Dr. Andrew Mouton, how are we doing today?
We're doing great.
We're here, we're alive.
Well, tell us, with COVID-19, right? Let's kind of start there. Like, how's everything going? What's life like in Chicago? Give our listeners a little bit of a sneak peek into the current state of affairs for you guys.
We're still under a government-imposed stay-at-home order, so we're not seeing patients in the office. We're doing sleep telemedicine. For testing right now, we're limited to home tests that we're sending out to patients or having them, I guess as of Monday, we're going to have them come to pick up the recorder in one of the offices. We found out that it takes 2 weeks to mail a home test across the city of Chicago. So we're abandoning that, but we were talking earlier, we're pretty much shut down. We're seeing about maybe 15% of our new patient volume. And of course, our dentists are planning, David, for a June 1 return, hopefully, with proper precautions and safety measures in place. So hopefully that's when we start coming back to life.
Yeah, we've been, obviously, from the dental side and the sleep side, we've been also at the stay-at-home in Illinois has been in place, will be in place until May 30th, although they gave dentists the ability to see elective patients starting on the 11th, which is a little bit of a conflict. So it kind of made us make some decisions and choices as far as whether or not we wanted to have that risk to our patients, to our staff. We made the decision to postpone everything until the stay-at-home was lifted and start seeing patients June 1st. Andrew and I were talking earlier today. We go back a long time, and I hope that genesis comes to light today. That's just it's important that people know that. But with as many patients, I think January we had 1,500 new patient referrals to the center.
1,540 new referrals in January.
Yeah. And that went down to how many this last month? 200?
About 200.
Yeah. So COVID has really taken its toll on everybody. It's not affecting anybody.
Yeah. Yeah. So thanks for that. Let me ask you guys to kind of discuss your practice, because the way that referrals happen between you two isn't necessarily like it would happen out there in the real world of private practice dentistry. So tell us a little bit, tell the audience a little bit about how the practice is set up.
Well, let me give you just a little bit of history, because go back 15 years ago, and it was pretty much set up the way that a lot of the practices are now. I had one particular sleep doc that I had grown to know and became friendly with, and I had a nice relationship with, and that was referral based, completely referral based. It was not integrated at all, and he and I had a good relationship. And he then went to work, I believe, as a medical director, wasn't he, Andrew?
Mm-hmm.
Yeah,
Mm-hmm.
at the Center for Sleep Medicine. In which case, now we had even a bigger inroads, because there was more sleep physicians that were part of that practice, and that's where that part started growing. It took I don't know how many meals and bottles of wine to finally convince Dr. Mouton that this model could work with a dentist in-house to facilitate that integration, to facilitate the referral process. At that point, we really didn't have a lot of the research that we have now, and I think it's still, I always use the expression Sisyphus pushing this boulder up the hill. But at this point, we finally were able to work out some arrangement, and I was going to 3 different locations at one point. And then soon after that, Dr. Lydia Sasenko, Dr. Wendy Shore, and Dr. Jean Sherman all joined the practice and are working out of different locations. So right now, it's a multidisciplinary. It's evolved. At that time, it was a multidisciplinary group. Up until recently, we had a full staff of specialists, including an ENT, on staff. So that's where that came from.
Gotcha. Dr. Mouton, anything to add there?
It made sense to me, because I don't know, 30, 40 years I've been doing this in one way or another, but one of the real attractions to me as a sleep specialist is that sleep is this interesting field that I think really doesn't really belong anywhere. It's not pulmonary, it's not ENT, it's not dental, it's not behavioral health, but in a way it's kind of all of those things. And so we were always big when this group started 20 years ago about being multi-specialty, if not multidisciplinary. So, we of course had neurology and pulmonary medicine. At the time, there was no such thing as an internal medicine sleep doctor or a family medicine sleep doctor. Or 20 years, there was really no dental sleep diplomat 20 years ago, David, was there? Or?
No, not 20 years ago.
Yeah.
But not quite.
But as sleep kind of evolved, it was sort of like, if you're gonna, I always, and I still believe this, if you're gonna do this in a comprehensive, well-rounded way, you have to have all of these different players. If not, it gets really fragmented.
Yeah.
So you need not just medicine and surgery, but you need dentistry, you need behavioral health, you need home health, all of these different pieces together. So that it's really not a referral, like you said, it's part of the practice. So if a patient has a sleep test, they come back to see one of us, we go over test results, we say, okay, these are your options, this, and this. And then whatever is decided upon, that gets scheduled right there when the patient's in the office. So in the case of oral appliance, if the patient says, well, I want to consult with the dentist or whatever, they get that appointment. Very often, when I'm up in Libertyville, I use Wendy Shore's office. So there's a dental chair in the room, and people are like, no, it's right here. The dentist will be here. And I think it's worked out just phenomenally well for the patients, because it's completely seamless. It's something we do in the office. I think one of the best things is that we were fortunate enough to add all of the oral appliance billing codes to our major medical contracts with the providers, Blue Cross, Aetna, Cigna, United, or whatever. So people can come to us in network if they choose an oral appliance. For most of our Blue Cross patients, which are probably 60% of the people coming through, lots of times an oral appliance is a $20 office copay.
Wow.
That's it. And it just makes the whole treatment accessible to the patient. One of the frustrations before we had this was you send someone to a dentist in the community. Dentists have ways around these insurance issues, but they don't have major medical contracts. And so you're trying to do it in the dental world, which is infinitely more difficult. David, would you agree?
Yeah,
for
absolutely.
coverage. Whereas with our patients, yeah, we have to do pre-certs and all that busy stuff, but I think it's fair to say now every carrier covers oral appliances. So if you have an apnea-hypopnea index greater than 5 and some symptom like daytime sleepiness, you're in. So we don't get a lot of pushback at all from insurance companies for patients who meet the criteria. There are a lot of patients who snore loudly and have an index of under 5 that we would love to treat with an oral appliance. And those are difficult because they would benefit immensely, but there's that silly 5 rule. I don't, some of those patients get retested.
I got you.
It's just it's nice having it all under one roof. There's continuity of care. Patients can follow up with the dentist. They can go back and see the sleep doctor if they need repeat testing. It's just all right in the same spot. And so it's all the same billing contract.
Let me ask you this, Dr. Mouton. At what point did you've been doing this a long time, like you said, but at what point did your oral appliance therapy light bulb go off where you realize, dang, this thing is an efficacious and a compliant therapy?
I can't trace it to a specific time. I think I'm probably a long-term believer, maybe longer than most. I like to say I don't have a dog in that race. I want something that's going to make the patient happy, that they're going to go back and tell the referring doctor how happy they are. That doctor won't know if we put them on an oral appliance, a CPAP machine, or a didgeridoo, or what's that instrument you can play. They just want, do you get a good outcome? How do you get a good outcome?
I think that, Louis, I think that when we go back to when the light bulb went off, not just for Andrew, but for a lot of the other docs in the practice, we had some pretty severe patients that had failed CPAP, put them on an appliance, and at that point we tested them, and it's still very much, we like to do follow-up testing on moderate and severe patients, of course, but these patients had they had no quality of life, and so now we get somebody on an appliance, we retest them, and I would run into a consult room with Andrew with the PSGs before and after, showing him, how we've reduced AHI. But more importantly, these patients were subjectively improved. They felt much better, and to me, that's where the satisfaction comes in. But I think that running in there, after the first 5 or 10 of those patients, I think that probably forced the issue a little bit more with Andrew, at least.
Well, where that even recently, where that's been really a big deal for us. We, in the last year, have brought on 9 physician assistant / nurse practitioners into the practice. And in cases where the dentist really made an effort to review cases, to just maybe see a patient that the PA had seen, bringing the case back to them, I just saw Mr. Jones, this is what he reports, here's his repeat sleep study. I think that has done a lot to really, really up the utilization. If people can actually see the cases, be part of the treatment team kind of thing, be educated, it's helpful.
Yeah. So what can the dental sleep industry do in both of y'all's opinions? And David, as the incoming president, I mean, this is probably a constant discussion, but what can the dental sleep industry do to help medical providers become even more comfortable scripting oral appliance therapy for more patients?
Well, you're right. We've talked a lot about this at the board level as far as our strategic plan about getting more public awareness, not only to patients, what the marketers would term low-hanging fruit, but to the physicians as well, because for many of our physician colleagues, they didn't know that this thing existed, that appliances existed, appliance therapy existed. And we've talked not only with you, with all the other manufacturers about how can we bring that awareness up overall. I think that education, it's got to start with education of our physician colleagues, not only from sleep physicians, but also our family practitioners, our integrative medicine doctors, our nurse practitioners, and PAs as well. And I think that is where it has to start. So, I like to tell a story. I was at a very large annual meeting, not ours, not the ASM review, with some of our docs, and this is just a few years ago. And the last lecture was a lecture by Peter Sestouli, presenting his study from Sestouli and Phillips' paper, and just talking about the amazing results that we have with oral appliances comparably to CPAP. And I thought, this is great. One of my docs is here. He's going to be referring patients, and we go back home to Chicago, and he's a doc who's on our staff. And it just was like pulling teeth for those of us who are dentists to get him to understand that this is a viable alternative. And I think, probably Andrew can speak more to that than I can, but that's been the biggest battle that we face is still that I think the docs like to control that therapy, and even though the research is there, we need another way of helping that education process continue.
Related to that too, I think for the sleep medicine practices out there like us, the bottom line is, we've been hammered. I like to tell people, and I started this practice in January of 2000, where at the time every apnea patient came in and had 2 laboratory studies, a diagnostic and a titration. At the time, Blue Cross paid about $2,800 each for those studies. Those 2 studies have been combined now and reduced to a $240 home test 20 years later. So we scramble. We have office visits, our procedures. The majority of patients coming through a sleep practice never see the inside of a sleep laboratory anymore because it's home testing and auto-PAP or oral appliance therapy. But incorporating oral appliance therapy into the practice is lucrative. I'll be honest. So as my dental friends know, they carry a fair amount of our overhead because the revenue is still pretty good. Our reimbursement, at least here in Illinois, I don't know about other states, but it's very helpful to the bottom line. Not that would motivate physicians to utilize oral appliances, but it might help to sort of start the discussion about why this would be a good addition to your practice.
You would have thought that would have been a motivating factor, and we had plenty of discussions about that with the physician staff. Like, listen, this is going to help the bottom line. That's going to help everybody. But that wasn't a motivating factor. They still felt that that CPAP was a better option.
Yeah.
Before I move on to my next question, because I want to stick on this clinical, the well-documented clinical efficacy of oral appliance therapy and all, and just talk real quickly about this new tool called the effectiveness equation that Dr. Schwartz has had the opportunity to see along with a dozen others. The effectiveness equation is basically it's a high quality professional tool to use with physicians to explain the clinical proof behind oral appliance therapy relative to CPAP. And I want to encourage those dentists that are on the call to get in touch with your SomnoMed rep and have him or her take you through this. It's a really, really cool tool. It's brand new. My sales team is still training on it as we speak. David, you saw this thing. It had to be now 3 weeks ago or so, and I don't think you've seen it since. But
I haven't seen it since. It's something. So for those that are listening to this webinar, more like an integrative. I'll equate it with this: is that when we get drug reps to come in, or we get reps from our dental representatives come in, they have an iPad that has a particular thing that they can show us something of how something works. This is a neat tool, and I think that it will help expand the knowledge base, at least from the physicians. But they'll be able to plug in numbers with a predictability aspect of it to utilize that feature to say, well, how would this particular patient who has an AHI of 20 phase out? And basically, from what I understand, and I don't know it, I've only seen it for a half an hour, they're taking a lot of the studies that were done not only by Sestouli and Phillips, but many other high-level papers, what's the criteria you guys were using to ascertain whether or not these were really good papers. But it's a really nice thing to be able to go in, and I think it'll help with education component to the docs that we're trying to make this point.
Yeah, cool. Yeah, I think so too. Switch gears a minute. Dr. Mouton, what are the most common concerns that patients tell their sleep doc when referring to the dentist?
I find a lot of patients, they don't know much about oral appliances, or maybe they just know they've seen like the internet boil and bites, or they've done a Google search because they know that they got tested for apnea or something. There is no one. I don't get questions about side effects. I don't get questions about efficacy. I don't get. What I'm more likely to get is, when can I get it? How soon? How long do I have to wait? Or does my insurance cover it? Yes.
You might rephrase that question and ask what the physicians are telling those patients when they're referring them to the dentist, that we would prefer that they don't talk about.
Okay.
Is
that a fair question, Andrew?
Boy, I've gone round and round. And maybe it's just because I'm old and getting a little more lazy, but if patients do ask a question about side effects, for example, well, I've heard that this can do that or the other thing or something, I tell them, you know what, if you're interested in this therapy, I want you to schedule an appointment to see the dentist, and they can answer all of those questions for you. And I completely dodge the whole thing, because there are a lot of biases out there. And unfortunately, I mean, I see these physicians that come to us maybe right out of fellowship training or whatever. And I say, so what's your experience with oral appliance therapy? Oh, I would never do that. My professor said that's horrible. That'll move your teeth, cause TMJ, and you'll never eat a steak again. And that's what they were told. That's what some old guy back east told them. Yeah. And I'm like, oh no, that's not. Yeah, maybe there's pros and cons to every therapy. So what I try to do is, and it's the same thing. I'll give you an example. My specialty is in insomnia, right? And so I struggle with these physicians a lot, because I don't want them telling the patient about sleep restriction, stimulus control, and whatnot. They will sabotage what I'm trying to do. So any kind of exposure to that sabotages the behavior therapy down. So the patient does some approximation of it and comes in and says, oh no, I did all of that, it didn't work. No, you didn't really do it. So my recommendation to physicians, if the patient is appropriate based on the polysomnography, meaning AHI, all of that kind of stuff, At that point, I think the discussion needs to shift to the dentist. So as a sleep specialist, my job is to tell you, do these numbers in this test make you a first-line candidate for this therapy? And if they do, I kind of see it as that's the end of my discussion at that point. I wanted to go with the dentist at that point. Well, what are the potential side effects? Well, I think that can vary from patient to patient based on the dental evaluation, right, David? So I can't tell you what your risk of any of that is. I'm not a dentist. And the dentists do a really good job of it. Maybe sometimes too good. We very, very rarely, can't think of a single patient that has gone for a consultation with the dentist and ultimately decided not to have an oral appliance fabricated. Do you know of any, unless you guys rule them out for dental reasons?
Well, no, not just dental reasons, but in Chicago, you know, we have a lot of people that are coming from Chicago CSO, for instance, the Chicago Symphony Orchestra, and some of these wind instrument players. I strongly discourage them from having an oral appliance. I usually say, give your CPAP a trial. If you cannot tolerate, then we're going to talk a little bit more seriously about what we can do to make an appliance that's not going to change your commissure so that they're not going to be no longer playing their instruments. But that's the only situation.
Interesting.
But there is a bias, and it's particularly, it's the old guard in sleep medicine. Do you know what I mean? The new guard is unfortunately trained by those folks, so they just kind of accept it as gospel. You know, that's what my professor told me. We were saying earlier, I have found that oral appliance therapy has been embraced phenomenally well by the physician assistants and the nurse practitioners. They don't bring the biases that come from medicine. And so all of these people in our practice have been trained in-house. So they're kind of going by what we tell them, which is, if the numbers line up, these are the options. And they're pretty good at doing it. When we made a big transition last year where we shifted all of the sleep study follow-ups to the PAs and NPs. So the decision-making regarding which therapy we're going to pursue is done with a PA. And we've seen a huge increase in oral appliance utilization. And I think it's just, it's freedom from the bias. If you spell it out and really present it in such a way that the patient is making an informed decision, there's a significant portion that will choose oral appliance therapy.
Have you encouraged staff to get their impressions taken and so that they can speak from experience, the use of oral appliance therapy?
Well, I have to tell you, it is ironic that you'll hear stories about this physician who's ordered 2 oral appliances in 8 years, but his wife is coming to see David next week for an oral appliance.
Oh, really?
That's happened in our group.
Oh, so, it's happened now.
Yeah. So I think just historically, yeah, there have been, I don't know about physicians on oral appliances, but I know a lot of our staff have been treated with them. So yeah.
Good. I just want to take a minute and tell our audience, if you've got a question, please type it into the question bar. We'll get to those at the end. It was never our intent to go a full hour. I want to switch gears, guys, and just ask you for your opinion. How does COVID-19 change the world of sleep medicine, in your opinion?
Where do we start? I think from the first part, you know, we live in a hermaphroditic world. We're dentists, we're physicians, and we work in the same facility. And as Andrew mentioned, and I think you can allude to it, the patients coming into that practice right now is dwindled. We're seeing more telehealth visits. You'll see some telehealth webinars that'll be at, telehealth information released by the Academy coming up pretty shortly. There was probably an AADSM news flash today that spoke of that. Our lives, our dental sleep lives, are going to forever change, and I think this is an opportunity. I think you have to look at it that way. Do we need to see every follow-up in front of us face to face if someone doesn't have any negative sequela? Can we do what we're doing right now face to face without having to see the patient? I think that the answer is yes, and I think that's going to change. I think these formats, whether it's GoToWebinar or Zoom or whatever it might be, we're going to start to see the ability for us to have a little bit more interaction with documents and things like that. So in my world, I think that COVID has really forced our hand into something that was discussed several years ago at the academy level. The AASM came out with a telemedicine platform. It never really had any traction. I can tell you right now, sites like DoxyMe and Zoom and GoToWebinar and FaceTime, that all those that are HIPAA compliant are being utilized every single day in the millions now.
In an odd sort of a way, I agree, David. I think telemedicine is sort of it's a gift of the virus, basically. So we rolled out telemedicine and we equipped every office and everything about 2 years ago for a host of reasons. It's infinitely more efficient. You know, in our downtown office, to park for an hour is what, $36 or something.
Yes.
Who wants to do that? You know, and who wants to fight the traffic or public transit, all this kind of stuff? We rolled out telemedicine. I think one physician did one visit in 2 years.
Wow.
And it was dead. And then the virus comes along and everybody's like, okay, get those cameras off the floor and get them back up on the monitors. We're going to do this. And I think telemedicine is now known as medicine, and it's not going back. And I think it's a great thing. I think it's efficient, and dental sleep is probably the most difficult part of sleep to utilize for telemedicine. But for the rest of what we do, this is a lot more like psychiatry than it is other. It can very efficiently be done remotely. So I'm hoping that stays. I don't want to ever go back. I want to keep as much, I think certainly by June, July, we want to be offering patients an option of coming in. But if they want telemedicine, I'm not turning back.
Do you think that COVID-19 will have any effect or influence on treatment decisions?
You're kind of leading into that. Is there an issue with aerosolizing the virus with an exhalation port? I don't know the answer to that, but I did offer to take David around to various firehouses in Chicago and have him scan all the firefighters who were being told they couldn't bring if they were not being allowed to bring CPAPs into the firehouse. Yes, I did see an opportunity there.
Yeah, that was, and that wasn't in Chicago, but that was in, I forget what city that I sent that to you.
Somewhere in Ohio or something.
Yeah.
But we could do it preemptively, you know what I mean?
Look, we posted on our website today on the AADSM a position statement regarding COVID-19 and the use of oral appliance therapy as a first-line choice. We know that we are not going to be spreading COVID in an environment through an oral appliance, but certainly, as the AASM has mentioned in their research, there is a risk involved in utilizing CPAP, albeit it may be slim. And if people have other rooms, then we want them to use CPAP. That's not what I'm saying. If they can isolate themselves.
Yeah.
So that's one way. I think between the increased utilization of oral appliance therapy as well as the telehealth, I think this is changing us. It is an opportunity for us to change the climate that we're working in and living in.
And I think one of the latest things to evolve, and we used to always think of CPAP or oral appliances, right? Why not both? So if I'm a firefighter who has to sleep 2 nights in the firehouse and I can't use CPAP, I should have an oral appliance. So one of the things I do with these young docs or these PAs is it's not an either or decision anymore. There's a ton of patients now that use both therapies, or there are patients who say, I travel 5 nights a month and I'm not going to travel with a CPAP machine. Okay, maybe this wasn't your first choice, but maybe it's better than no therapy at all, or maybe it's 70% effective versus the 100 for your CPAP, but for 4 or 5 nights a month, that's better. That's fine. That's an acceptable. What is the term you guys like, David? Disease burden? Is that the or whatever?
Maximum disease alleviation.
But I tell that patients too, when I'm telling them about, there's CPAP, there's oral appliances. Yeah, you usually choose one for starters, but it's not like luggage or it's like it's not a lifelong. You can have both. You can do both, and you can go back and forth between the two therapies. And if you're a camper or something, maybe you use your oral appliance. So we have to get away from thinking that it's CPAP or oral appliances.
Right.
For a lot of these patients, they should have both. And maybe if it turns out that firefighters are at risk with CPAP machines in a firehouse, and they ought to have an oral appliance.
Most definitely.
So David, tonight we'll be going to firehouse number 56. Bring your scanner.
I totally agree with that. It was less than a year ago, big tornadoes ravaged some of the most high rent areas of Dallas, and there were some really, really big houses that were damaged and whatever, but they didn't have power down in that neck of the woods for 3 days, and you just can't help but wonder, what are these poor people doing without their CPAP? So, yeah, hey, I'm a big proponent of if your dog chews it up, if you lose it, if you're going camping, whatever, have something to fall back on.
Have a backup, sure.
No.
We find most insurance companies that will go along with that. Maybe not both of them right out of the chute, but particularly if it's going to be short-term use or irregular, I think you lessen the risk of certain side effects, right, David? You lessen the likelihood of bite changes.
I'm a big advocate of that, where I've got a lot of patients who will travel during the week. They use their appliance to come back and they use their CPAP, and it does mitigate a lot of the bite changes and tooth movements that we see. So.
There's so many things in history when you find out what's better, A or B. Probably A and B is the, when I was in graduate school 1,000 years ago, all the research, what's better for depression, psychotherapy or antidepressants? The answer is both. the best treatment is, and I wish people would start thinking like CPAP and oral appliances that way.
We'll look at a couple of the questions. We've been going for 40 minutes, so we're kind of nearing the time that I wanted to wrap this up. Dr. Jay Newhouse in New York says he saw the effectiveness equation yesterday. Teresa showed it to him. He says it's great. Awesome, Jay. Love to hear it. Does this mean that your dentist works at the PCP's office in your practice?
No, not the PCP, the sleep physician, the sleep medicine practice.
Yep. Okay. Did Dr. Andrews suggest that by having a dentist at the PCP's office, not the case, but continuing to read, at the PCP's office, will that help accept will this help the patient accept the therapy and reduce the co-pays for the patient? In that I can see under one roof, right?
Absolutely. I think it probably does increase the likelihood that they'll choose this therapy if it's already in-house and it's a place that they're familiar with, and this is where I had my test done and it's going to be done by this person who's a partner in my sleep doctor. Yes, I think it lends a lot of credibility to it.
Let me chime in for just a second, because I think that the most important thing for these people to understand is that there are choices. Most patients will not get a sleep test. right now because they only think that they're going to be slapped with a CPAP when they leave that facility. So if they think that the only answer to their nail is a hammer, they are not going to even come in for a test.
Yeah.
They'll rather go online and buy something for their snoring, if you will, before they come in to have a full-blown study. One of the things that the dentists really worked on with our marketing team is getting posters up in each location. So when people are in the reception area, which that won't be happening much anymore, but when people are in the reception area, they see that there is an alternative, and it spells it out right there for them. So.
Yeah. Well, and we also push that a lot with our marketers. So when they go out calling on the primary care doctors, we let them know we have options other than CPAP. Because like David said, a lot of patients may tell the primary care doctor, I don't want to go for a sleep test because I don't want the machine. Yeah. But we say to the primary care doctor, no, don't, you're getting ahead of yourself. Tell them to just come and talk to us. Let's have a conversation even before we do any testing. And yes, we offer alternatives. We actually, David, didn't you fabricated appliances for all of our marketers?
I think Wendy had done that for many of them. Yeah.
So when they go and call on a primary care doctor, they can pull out the appliance and say, "Look at this." I think that was a brilliant move. So yeah, that's an ongoing battle. You know, sleep medicine is really more than sleep apnea, which is really more than CPAP.
Good point.
Dr. Carstensen asked a question here. Does having a therapist in the same office as diagnostics create a problem for Medicare patients?
Medicare is the one oral appliance service that it's the one population that we don't do oral appliances for, because there is a screwy thing in Medicare. The provider, of course, has to be a DME company, and we have an in-house DME company that we own and operate. There's no problem there, but there's also a provision in Medicare that says that the DME company must be a dentist, which I think is really, really odd. So what we're able to do for Medicare patients that want an oral appliance, we're able to send them to someone in the community who's a Medicare provider. So Medicare is the one population we don't treat with oral appliances. But they're a small, I bet they're 15 to 18% of our practice. We don't see a ton of it. And I don't know that those regulations are almost uninterpretable to me. Maybe there's a way to do it, I don't know. But there are dentists in the community who accept Medicare for oral appliance. So we kind of have a little network of those folks that we can send the patient to.
Gotcha. Okay. Reading a text from Dr. Wendy Shore. Nice webinar. I made our marketer a SomnoMed. Thank you, Dr. Shore. Love to hear. We don't have any more questions, guys. Let's wrap it up and let everybody get their weekend started. Guys, I cannot thank you enough for being our guinea pig on webinar number 1. For our listeners, tune in next Wednesday where Dr. Kent Smith will be on with Mike Ring, his full-time sales and marketing guy. Okay, should be a good time on Wednesday of next week. That'll be it from us. Dr. Schwartz, Dr. Mouton, thank you guys. Really appreciate it. Appreciate the insight. Love the insight. I know everybody else did too. Let's have you on again sometime. Thanks so much for your time.
Look forward to it. Thank you so much.
Bye, guys. Have a good weekend.
Bye-bye.
Take care. Bye.